Welcome to RhAPPcast, the official podcast for Rheumatology Advanced Practice Providers. I'm Amanda Mixon, your host and current president of RhAPP. Thank you so much for joining us today for an exciting and innovative episode called Navigating Remission in Rheumatoid Arthritis: Approaches, Advances, Impacts, and Insights. In this episode, we're going to dive deep into the topic of remission in rheumatoid arthritis, exploring the latest approaches, significant advancements, and the profound impact that remission can have on our patients' lives. To help guide us through this virtual discussion, I'm thrilled to welcome Wendy Simmons, a highly esteemed board member of RhAPP and expert in the field. I like to call Wendy the OG of rheumatology because you've been in it for so long and truly, have seen the impact of some of these medications that they've had, on our patients' lives, even from the very beginning. I always like to talk about when I first started in rheumatology, how we were still giving people gold and, you'd see people coming in wheelchairs. And obviously we don't really see that anymore, but you've even seen it, obviously longer than I have. And so thanks so much for being here, Wendy.
Amanda, thank you so much. I really appreciate being included to have conversation with you on this podcast. Very important topic for our community. And as you said, various experiences with our patients.
Wendy, how long have you been in rheumatology now?
So 26 years, Amanda, just the tail end of gold. So definitely have that opportunity to see patients. And I'll use one of my patients as a great example today. But just to really see how all the therapies and evaluations have evolved.
Absolutely. I mean, remission in rheumatoid arthritis, of course, is the goal that we strive for in our practice. And with this kind of ever evolving landscape of treatment, options and strategies, it's crucial that we stay informed and share best practices. So today we're going to cover the various approaches to achieving remission, the latest advancements in treatment, and the overall impact that these developments have had on patient outcomes. We'll also delve into practical insights that can help our listeners in their day-to-day clinical practice. I always, again, think about when I started in rheumatology, it was kind of the era of the biologics because, we had some of the TNFs. But that was really, kind of it when I first started. And so I can't even imagine what it would be like to be a new practitioner coming into the field with so many options, but also how amazing to come into the field of rheumatology with so many options. So, I'm super excited for the podcast today, and I can't think of a better, person to be on this. So, let's go ahead and dive right in. So, Wendy, can you start by defining, what remission in rheumatoid arthritis means from a clinical perspective? And then also, I would say, what are the widely accepted criteria for determining remission in rheumatoid arthritis? And how have these criteria evolved over time?
Absolutely. So, Amanda, really, I feel no matter what point that you're stepping into rheumatology as an APP provider and seeing those patients, we all have those unique rheumatoid arthritis patients and see them early disease. There's still patients out there with long-standing disease. So we do certainly all have that opportunity to have our clinical evaluation. So clinical remission, basically we want to halt that disease in the tracks, right? We want to be able to relieve that patient of their pain, their swelling of their joints, have quality of life, really, reduce and put into remission that disease activity. We want to have that goal of eliminating that smoldering disease and prevent the joint destruction ultimately, which as we know can lead to deformities and disabilities as well. And there are criteria for this goal of clinical remission. We want to have at least one or less tender or swollen joint, on our joint counts for the patient. We look at our patient assessments. We want to know, how do they see their disease activity with regards to their joints on a scale of 0 to 10. We really want to, again, also reduce that to 1 or less as well. And, that we do have to take into consideration our lab, our CRP value. We know that CRPs can reflect, many disease processes or the patient's, general health. However, when we have that baseline marker, that is something that we can watch the CRP go down as well when we're treating our patients, to use that as a gauge, when we're treating them. So these really together, I feel, follow the criteria. And then, finally, as you asked, how have these criteria evolved over time? You certainly mentioned, my time seeing patients, you know, we didn't have, I think, this combination of being able to evaluate. This has evolved. I think this has helped us with that smoldering disease, to lead us and guide us of, what do we do? Do we add therapies? Can we take away therapies as well? But again, ultimately, leading to that prevention of the joint destruction as well. But we've done a great job over the years, I think, being able to define the criteria and then be able to follow that and have something more streamlined for all of us as we learn and get through our unique patients in rheumatology.
Yeah, I mean, I love what you said about, even checking the CRP. I sometimes feel like patients, they need something, obviously they feel better, right? Like when we start to get their disease under better control.
Right.
But I think also having something objective on a blood test, I think can help patients. And, understanding that CRP being elevated isn't, just about your damage that potentially is happening, but the cardiovascular implications and things like that. And because I feel like patients often, they need more than just, I feel better. I mean, obviously that's really important to them, but also knowing that there are other things that can help guide us to make sure. And also the flip, because sometimes you check that CRP, or it's radiographs or whatever it is. And the patient says, but no, you should have seen how I felt before. I don't want to make any changes to therapy, but you're like, but your markers of inflammation are still elevated. And, you've had radiographic progression. And so I don't know. I just feel like we need more than just the, rapid 3 or whatever you do in your clinic to assess the patient. But also some objective evidence as well, because sometimes when they start feeling better, they don't want to do anything else, even if we kind of feel like their disease isn't where we want it to be.
You're absolutely correct, Amanda. And really to your point, it's helping us guide our conversations with the patients. And it's really helping us, as you mentioned, tie everything in together, comorbidities, what else can be potentially affecting their arthritis as well. And really, I feel that for myself too, and all of us, perhaps in the past, before we had all these criteria to lead us and guide us and bring in these conversations, basically smoldering disease is not good. And perhaps maybe in my earlier years, that's what we had. That's what, had to be good. But now we don't have to settle for that. So great point. Thank you.
Yeah. So what do you feel are some of the most effective approaches or strategies currently? We kind of alluded a little bit to some of them, but, that can be used to achieve, remission in rheumatoid arthritis patients.
I really feel that, for those effective approaches and strategies, obviously we want to have the conversations with our patients and, joint decision making. And we want to understand, what direction our patient is coming from. But at the same time, to your point of mentioning, you have the CRP levels, we have those tools, we have the real evidence to, explain to our patient, what their disease is like. So I feel like having the conversations, letting them understand, their disease, also having them have a little bit more, control of their decisions and, having them understand, really what's going on. I feel like through using that criteria, as a build, as a platform, being able to, explain to them, what remission can be and letting them know, you don't want to end up being in a wheelchair. Just, there's no need to be that way in 2024 with our therapies that we have as well. I think, the monitoring, like the lab, the ultrasound, being able to evaluate active inflammation before we see radiographic changes. I feel like those are definitely, strategies. Of course, we have patients coming to us in all different forms of their disease, maybe milder disease. We know this is, RA can be very aggressive. And we want to get on this early. We want to be aggressive with our therapies as well and not spread out that time with monitoring and treating. Perhaps they've been through NSAIDs, steroids. We want to be able to onboard those DMARDs. And fortunately now we can advance certain treatment strategies with biologics and JAK inhibitors as well. So early aggressive treatment, goal for success with our patients.
Absolutely. And you're really, kind of leading me right into my next question, which is talk to me a little bit about some of the recent advancements in RA treatment, because obviously number one, I can't think of somebody better to discuss this than you, just because you've seen this evolution, like I have. And, for our listeners that, maybe are newer that, haven't really, kind of been around long enough to see this evolution happen. Can you talk a little bit about that?
Yeah, absolutely. And, I think about one of my patients. We always tend to go to those patients that we have. And, we're really one of my tougher patients, and they still are out there. So though we have these amazing biologics and JAK inhibitors, advancements of therapies, we also cannot forget that, there are patients out there that have let disease take a hold of them. They're still out there. I do see patients that come in from rural areas that maybe haven't had time or you didn't want to go to the doctor, or that perhaps have been with a rural community physician. One of my young patients that was in her 40s, her came in with her mother, and she had rheumatoid nodules on her forearms. She basically had been treated with methotrexate by her primary care. She was at the point that she could not write checks from her checkbook. She couldn't take care of herself and her hygiene, and it was very difficult. So that patient really, and she came in at a time when biologics were out there. So she had been on methotrexate. This is a great example of how you want to be early on to treatment, aggressive with therapies, use your tools to evaluate that patient. So certainly moved quickly from methotrexate to a biologic therapy. And, it's important to monitor the patients. You want to bring them in pretty frequently, let them know they have access to your clinic, to you, to be able to let you know how they're doing and assess them when they come in. But with this patient, lost efficacy. And she has now been on a JAK therapy, a JAK inhibition, which is, really our latest advancements of treatments that have been proving now to be quite successful for the patients. Her rheumatoid nodules are now gone. She has significantly improved back to what I don't think she ever knew as a normal quality of life, taking care of herself, taking care of her mother, and being able to, can imagine not even writing a check from a checkbook. So I know that that's an example of where we don't want our patients to go, but an example of how we can advance through the therapies as well. I feel that, we want to individualize our approaches for our patients. We want to be sure that, we have those conversations in the treatment plan as well. I know certainly in research right now, there's also, more advancement potential with JAK inhibition and possibly other, therapy models for those patients. I've had patients that have been crippled with arthritis that have been artists and been pretty almost famous, as well as those that have made wedding cakes. So we want to be able to stop the disease, and I think the advancement of the medicines are helping.
Absolutely. And, it's so interesting too, kind of that talking about people kind of coming from maybe areas that, just don't have, maybe they're not on the forefront, of what's going on. Where I practice, same, we have people come from kind of all over in more rural areas. And sometimes I'm, it's easy to kind, I don't want to say judge, but it's easy to be like, oh my gosh, I can't believe that they're doing that there, or that's the treatment that they've been on. But I think also recognizing that rural providers are just, kind of doing the best that they can with the tools that they have. And, but I can think of also patients just like that come in and, something similar, right? Like they've been treated with maybe an older therapy, or maybe they're not on the optimal dosage of something, and also not being followed regularly, right? Like I saw a patient not too long ago that literally was being followed once a year, and clearly not in remission, clearly, still struggling, but didn't know, you only know what you know. And so, had to have kind of one of those breakthrough conversations, like, we need to follow you more frequently. We can make changes. This is not good enough, and we can do better. And so I think that kind of is going to lead me into what my next question for you is. Talk to me about the challenges, talk to me about the obstacles that you experience when you're dealing with patients who have active RA and you're really trying to get to that remission standpoint.
Certainly. So with all that information that you just provided as well, those patients develop confidence in us as well, right? They're then encouraged, and they see that there are advancements in those therapies. There is potential of remission. Their quality of life gets better. But some of these patients, compliance certainly, can be a concern. Their comorbidities might interfere, providing challenges as well. And so these are more conversations that we have, just not about, as you mentioned earlier, just the joints as well. It's their whole just health and disease process. Infections entering in. How are we going to manage these advanced therapies for keeping that patient in remission? We see flares. Those are challenges, right? We never know. That's something that we face every day. We might have had those patients in a remission state. And as we know, the RA can just take off like a freight train. Things can change, whether it's loss of efficacy. Did they have an infection that set their immune system off and, really rechange things for that patient? But I feel like distance traveling, insurance, many barriers as well. And I think for us to really spend the time to know where our patient is when we see them in clinic. And as you mentioned, do we need to bring them in more often? We can understand those patients. I know back to a little bit with the advancement of therapies with the biologics and JAK inhibitors, people are feeling great. Their disease is much better under control and in remission. So then patients try to tell us, well, I really don't want to come back at 3 months. I don't want to come back at 4. I've got a busy lifestyle. Can I stretch it to 6? One of my younger patients as well with RA that has cycled and moved through therapy through DMARDs, biologic, and is on a JAK inhibitor, said to me, I'm feeling so great. I've been like this now, Wendy, for a year. I feel like everything is resolved. And he said, I want to stop my JAK inhibitor. I want to just, follow. I said, listen, the reason you do feel so great, the reason we have halted your disease is because of this medication. And your disease most likely will at some point come back. And I can't tell you at what state that will be. That could be pretty aggressive coming back. And that was like one of my stories I'm not necessarily proud of, only because I feel like, as providers, we want the best. We want to be 100% the best provider and have feel like we've accomplished and helped that patient. And, did I lack something in my conversation preventing him from stopping? But he came in absolutely with that decision made in his head. He was going to stop. Sure enough, this past month, he came back. My MA called me, said, Wendy, he wants to get back on his JAK inhibitor. I said, he really needs to come in. And I think to your point too of following and talking with those patients, getting through these challenges, we really need to bring them in our clinic if we can. And literally, I had no problem restarting medication.
Yeah, it's, I think it's pretty remarkable that, we get to have these, remission is the norm now, right? Like, I mean, and to your point, like before it really, not that it wasn't, but we just didn't have that many options. So like, if you kind of ran out of your options, then it was like, well, we're just going to kind of do what we can, But then to your point, that's the question. We've achieved remission. You have no swollen or tender joints. There's not been any kind of progression either on ultrasound and labs and what you're seeing, et cetera. Now what? Now what do you do? And I think that's where a lot of like the research and it is being done is, then what do you do? Because the other thing too, this, which kind of gets off a little bit, but what about as people get older, like getting into their 60s and 70s? Like, do you still keep them on their therapy? I mean, and again, I don't have the answer, but this is something I'm grappling with because I have been in rheumatology so long. And I tell my patients, we're kind of getting old together. And, what do you do? Do you keep somebody on, their therapies into their, later years of life? And, again, I don't have the answer. And, but I think these are the things that it's also incredible that we're able to have these discussions because we're able to achieve that with our patients, right?
It is. And I think really now we've, all had experience, with these patients, with therapies, but also earlier to your point about newer APP providers and, jumping in and learning about all the biologics. I think it's important, to learn really the key is remission, stop that smoldering disease as well, monitor your patients. All our rheumatology practices are so full. And I feel it's, again, so important. These are the patients when we look at, we need to bring back in if we can, to get them on our schedule. Or, if you're working with a rheumatologist and, you're sharing panels, be there for that rheumatologist to be able to help get these patients in as well.
I love it. And you've already given us so many good ideas for, our listeners, but what about, do you have any other practical tips, strategies, kind of to help our APP colleagues on how they might approach managing rheumatoid arthritis and kind of striving for remission?
Yeah, definitely upfront, understanding just the getting on treatment early, aggressive, bringing those patients in, not waiting too long, using what you are able to use in your area or your office with regards to lab monitoring, physical exams, certainly key, ultrasound, labs, and early on setting the platform for treatments that are potential treatments that you will move on to with the patient. As long as, they're educated and you have a great conversation with them, we are helping these patients through their journey, and literally we are helping them. This isn't necessarily going to ever really go away. It's lifelong, and we're on their path with them. So for them to have the confidence and, comfort to know that they can call us and come see us, I think that's important. But continuing educating, continuing monitoring, let them be part of those decision-making conversations as well. Being great listeners as we are, I feel, it's tremendous and leads us to be able to help them. And for us to stay on top of all the current, data and advancements, whether or not I have that patient that has mild disease or it's another patient like that I gave the example that comes in that I'm really having to move quickly and prevent anything further happening with joint damage or disability.
I love all of that. So what I'm hearing is bring people in frequently, reassess frequently, set good expectations, right? Like, with our patients, having them really also be advocates for themselves. Like, we're a team, but like, you have to feel good about it too. And, again, really like letting patients know, we can achieve this. You can be back to how you were before you had this. And then I heard you say kind of finally making sure that we stay up to date. We always have to learn. We always have to, try to look into the future and stay current so that we can be the best, for our patients. I think all of those things are just so crucial. One thing I do is if I see somebody that I'm kind of questioning, like, I don't know if this drug is working, but again, I always try to remember, how did they feel before? Because sometimes they don't want to change because of how they felt before they had the disease. And, but also kind of just putting like putting the idea of it, like, I think you're doing okay. Obviously, like, we can continue. I'm not telling you we have to stop or change to something else, but maybe do some reading on X medication or Y medication. Cause this is where my brain is going. If I see you next time and I still see 5 swollen joints, I might be thinking about making this change. Do you ever do that with your patients?
Yeah, absolutely. I'm just thinking about a few of the points that you've highlighted as well, Amanda. And one thing that I remember, usually it's always that first visit I had with that patient and, where they were in their disease and what their joints looked like and what they were able to do and not do. Asked me about many visits in between over the years, but that first visit definitely always usually stands out because I remember how poorly that patient was at that visit. Certainly a great gauge, but I think also to what you talk about is find out with that patient what makes them happy. What is their day to day? What is important for them? Is it something that they do with their family, some type of a hobby or sports activity? And really, I think that's just a common thread, as well to help you gauge in the midst of all the tools in our toolbox to evaluate patients.
Yeah, I feel like that is something that APP shine on, is like really getting to know our
Right.
patients.
Right.
And like, and that's something else too, for listeners maybe that are newer APPs, I can tell you one thing that has really helped me because I've done it all, right? Like I've been in clinics where I didn't see any new patients. I just, saw follow-up patients. Now currently I have my own panel, just like you do. But I do think there is something to be said about starting the journey with a patient. And if at all that's a possibility for you to see new patients, that way you're the first one that has really, talked with them, touched their joints, been on the journey from the start. I feel like that, at least in my experience, has really been helpful, not only in learning how to diagnose, like I feel like when you're the one kind of doing the assessment and whether maybe you're talking to your attending and, you're supervising, doctor and you're saying, hey, here's the story. And then maybe the doctor comes in, afterward, just to kind of make sure if you're newer. But I do feel like that if you're able to start the journey, I feel like that creates this like trust and confidence in you as the practitioner and them as the patient to like that when we do say things like, you know what, I know you feel like you're doing okay, but it's not enough. I feel like that adds a level of, trust that maybe they wouldn't have otherwise if you were more involved in the middle of the journey. Do you know what I mean?
It really does, Amanda. And I think, like, lastly, for one of my points, realizing, and for newer APPs as well, maybe this comes with some experience, that really trying to find out where your patient stands as far as how stoic are they. That's something that could be easily missed by any of us, not just necessarily a newer APP, because some of those patients, as you know, they're quite stoic and they will come in and tell you how well they feel they're doing and they don't want to complain. We have everything on the spectrum to those that will complain about everything to those that won't. And we really want to learn where that patient falls with regards, how stoic they are, what is their tolerance when we're evaluating their disease activity, and are they remaining in remission and are they there?
Absolutely. I mean, well, Wendy, I'm sure you and I could literally sit and have this conversation for hours. But, again, I think we hit some really important points, hopefully some practical tips for our listeners. And, again, just remember, remission is the goal and it should be the goal. And we have way too many options to not achieve that with our patients.
True.
So with that, it brings us to the end of our episode today of RhAPPcast. We definitely hope that you have found this discussion on navigating remission and rheumatoid arthritis to be insightful and inspiring. Thank you so much, Wendy, for being here. Your expertise is obviously so valuable. You add such a great perspective, for our listeners.
Thank you, Amanda. It's really been a pleasure as well to be part of the conversation, especially with you this morning, and to be able to contribute to our shared goal of improving our patient outcomes, as well as helping everyone out there. So thank you as well, Amanda.
Absolutely. I mean, obviously, definitely need to have you come back on RhAPPcast because, you just do such a wonderful job. And it's probably pretty clear to our listeners what, good friends we are because we do chat a lot. And so, we always have something insightful, I think, to say to each other, but also hopefully to our APP colleagues. So, listeners, thank you so much for tuning in. I hope that you've enjoyed this episode. Please be sure to subscribe to RhAPPcast on your favorite platform. And leave us a review. Let us know how we're doing, what we can do better, what you'd like to hear. There has been such an evolution in this podcast that it was beyond my wildest dreams, as well as the amount of listeners that continue to grow. And, let us know what you want to hear, because I think that's really important. This is, your platform. And so, I'm happy to talk with anyone and about, all things rheumatology. Also, please stay connected to us on all social media at RhAPP. Please visit our website, rhapp.org, for more resources and updates on everything Rheumatology Advanced Practice Providers. So until next time, again, I'm Amanda Mixon, reminding you to stay informed, stay engaged, and, keep making a difference in the lives of your patients.